Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. This is Steve Caselli, Executive Director at ICOS, and we're at the Memorial Sloan Kettering Cardio-Oncology Symposium. It is May 2nd. We're glad to be here with some friends and colleagues. Dan Lenihan, co-founder of ICOS, and one of our good colleagues from Toronto, Canada, Dinesh Thavendiranathan. And we are glad to speak with him today about some of the clinical trials that he's engaging in.
Thank you so much, Steve. It's absolutely a pleasure to be here with both of you.
So, Dinesh, it is a beautiful day here in New York, and we're very thankful to be involved with the Sloan Kettering annual update. But I understand from some of our previous conversations that you're involved in two clinical trials that are specifically in the cardio-oncology space. I was wondering if you could just explain a little bit about that, and perhaps some of our listeners could be involved if that's appropriate. But anyway, please let us know what you're up to.
Thank you, Dan. I think we'll perhaps split up our trials into two, and then I'll stop in between them with an opportunity to ask questions if that's okay with you. So the first trial is the Himalayas trial, just like the mountain, the Himalayas. And the trial is one that's funded by the Canadian Cancer Society and the Canadian Institute of Health Research, which is sort of the NIH equivalent in the United States. So this trial, designed a few years ago, really was based on our clinical experience in caring for patients after cancer therapy. We see a few things in these patients. First is fatigue, which was a big issue in these patients, which impacts their quality of life. And a small group of patients will also have mild heart dysfunction, which we refer to as stage B heart failure. And we were interested in the adolescent and young adult populations for a couple of reasons. One is that many of them get toxic cancer therapy. They're all going through a stage in their life where there are a lot of competing priorities, which they have to balance. So convince them to take a medicine on a regular basis when they've got stage B heart failure is probably not the best thing to do. So we asked the question, how do we deal with all of these issues, the fatigue, the low mood, the mild stage B heart failure? And we looked into an exercise-based program to help these patients. So the Himalayas is really a randomized control trial where we're randomizing patients to cardio-oncology rehabilitation, similar to if you're admitted with heart failure or admitted with coronary disease, versus standard of care, which is me saying the AHA guidelines, the core guidelines say you should exercise 150 minutes a week and go ahead and do this. So as opposed to telling them what to do, in the intervention arm, we're providing a structured intervention. So what we're doing in the structured intervention is that each patient gets a watch where we can actually monitor their physical activity level. Each patient gets a bike delivered to their house so that they can exercise. Once a week, they come into our rehab center where they have high-intensity interval training that's offered to them. And twice a week, our kinesiologist monitors them at home as they exercise. So it's a 6-month program where they have this active intervention. And we are also dealing with a few other things. For example, we are dealing with their smoking cessation issues. We are dealing with, if they have risk factors, managing that, and also their psychosocial challenges as well. And the primary question we're asking is at the end of that 6 months intervention, are these patients better from a cardiovascular perspective? Is their fatigue better? Is their quality of life better? Is their mood better? And then we also will continue to follow them for 2 years afterwards, just to ensure that the activities that we are teaching these individuals, they can sustain it. So the trial has been recruiting. We've been working on this trial for a couple of years. We've been recruiting actively for the past 2 months. We already have 10 patients randomized within the trial. Our goal is to randomize about 335 individuals, and it's being run out of 4 Canadian centers.
Oh, wow. That's really incredible. And so would there be a possibility for any non-Canadian sites to participate if they could kind of have the wherewithal to do the types of things that you're talking about?
Yeah, absolutely, Dan. I think it is definitely something we can talk about. As you would imagine, the challenges are that you would need a center that can offer rehabilitation facilities, after their stage B heart dysfunction is detected, and you would need the vendors in the other countries to be able to send a bike home to those individuals who are randomized to that active arm. So if all those facilities are available, we would be more than willing to consider other centers if they want to reach out to me.
Yeah, that's really fascinating. And what is the age limit of the people that you're enrolling?
Yeah, the age limit is that they must have had their cancer before the age of 39, and their present age must be less than 45.
Okay, so young adult survivors who are not that old.
That's correct.
Especially when you're in your 60s, then you're talking about young people, right?
Absolutely.
Okay,
and I
good.
think these young people really need this kind of support as they are kind of struggling through the early parts of their independent life, having kids, getting married, having essentially a new job. We're trying to make sure that we can provide the best support we can, after having essentially been through a major change in their life, which is cancer and its treatment.
Wow, that is really fantastic. I think, for those of us who have been interested in exercise as a therapy for years, I mean, it's clear that people who undergo cancer treatment, whatever that is, which usually is some combination of chemotherapy and radiation and surgery and who knows what else, that their functional status never gets back to what it was. And part of that is because of the treatments that they're receiving, but even well after they're no longer receiving treatment, their general activity levels have diminished for so long that they basically can never recover. And then the other part is, especially for cancer survivors historically, once they get to the 5-year interval or 3-year interval, depending on which cancer you're talking about, and they, quote, get to ring the bell, they don't ever want to see another doctor again. And so that's they have a lot of problems that are developing they may not be aware of, mainly because they want to get out of the healthcare system. Have you encountered those sort of general feelings?
Yeah, absolutely, Dan. I think even at the end of cancer therapy, you tell the patient that, I'd like to bring you back for follow-up in a year, and their response is, look, coming here reminds me of my cancer, and I really want to try to avoid coming back for follow-up. And yeah, absolutely. I think everything you said is spot on. Even the exercise intolerance and the need for some form of structure. And if you look at surveys that have been done in the adolescent and young adult cancer survivors and ask them what motivates them to exercise, the two things that come over and over again is supported exercise, somebody watches them, and the ability to exercise with peers. And we are addressing both of that in the trial as well.
Oh, that's super good. Well, and I remember in the heart failure space, I forgot the name of the big trial looking at cardiac rehab in people with heart failure, that they sent everybody a treadmill. So the patients were randomized to supervised exercise or home-based exercise, and everybody got a treadmill. And this is a big study, and I'm blanking on the name of it, but we were part of that at the time. And they really showed a dramatic benefit from exercise in heart failure patients with LV dysfunction. But it wasn't, they didn't show, say, a mortality difference or some sort of hard outcome difference. And so, at least in the United States, getting approval for cardiac rehab in a person with heart failure is still pretty difficult.
Yeah.
Only if their EF is less than 35 and they're symptomatic. So, expanding the whole cardiac rehab to a cardio-oncology population is a major challenge, because here you're talking about, these are people that they are symptomatic, like you said, from some degree of heart failure, but their EF is not very low. And so how are you going to get any sort of payer system to pay for cardiac rehab, even if it's home-based, and that's a real challenge.
Yeah, Dan, I think spot on, an excellent question. So, as we designed this trial, one of the things that we decided to do in parallel is to have an implementation science specialist who is part of our team. So the implementation science specialist's responsibility is to figure out, based on what we learn from the trial, who says no, how do they pay for it, how does it interfere with their work, quality of life, etc., to help us then eventually implement this in real life. But obviously it comes back down to cost, right? If I'm sending bikes to individuals' home, who's going to pay for that bike? Right now we are fortunate that one of the companies have given us bikes at tremendous discount, but that's not going to be feasible. So we've also added a cost effectiveness part in there as well to help us understand the cost effectiveness of such an approach. And we'll have to see what the final outcome is, right? If we are seeing improvement in cardiopulmonary fitness, patient quality of life, perhaps reduced readmission for reasons that are maybe psychological in nature or heart failure in nature, given the fact that bikes are not as expensive as treadmills, maybe we'll find some degree of cost effectiveness. So we have been thinking about this, and we've also engaged our individuals who are on the government side who actually make a decision in approving rehab programs, who are also engaged from the study from the beginning. So they are aware that we're doing something like this to generate data to eventually be able to have something like this sustainable even in a public healthcare system like ours.
Yeah, and I think the other point is, so we designed a study about home-based exercise versus supervised in a small population of patients with lung cancer, and we're sort of just at the beginning part of enrolling that. But the real question is the home-based exercise. Have you developed some sort of app, or what tool do you use to help the patient on their home-based program?
Yeah, that's a great question. So, one of the things we have learned is that when you send patients away and ask them to exercise, it's very difficult for them to follow those instructions. So our home-based delivery is actually based on our current rehab model in non-cardio-oncology population, which is a virtual platform, something like Zoom, where a kinesiologist actually monitors them at a fixed time as they exercise. So to keep individuals motivated, they have an appointment which they are attending, except they are attending the appointment at home. We also, in order to titrate the exercise, because we are doing HIIT, they come in once every 2 weeks and we get cardiopulmonary data in these individuals, not once every 2 weeks, but once every few weeks, to titrate their exercise and give them an exercise prescription. We're able to monitor that exercise prescription virtually. So this is how we're trying to keep them engaged throughout the study period. Now, what happens after that, of course, remains to be seen whether that's sustainable or not.
Yeah, I mean, wow, this is really interesting and a tremendous effort on your part, and I congratulate you on that. I think both groups are going to benefit, for sure. And so then you may have a difficult time showing a difference between one strategy versus another. Is there a non-randomized control group so that you could possibly see the difference in terms of organized exercise versus home-based exercise versus couch potato?
Yeah, no, I think that's a great question, Dan. I think that first of all, in the control arm, remember, all we're doing them is giving them a Fitbit device and say, you should be exercising 90 to 150 minutes per week. That's it, right? So that's like what you would do today in your clinical practice at the end. So we know that doesn't probably work because that's not changing behavior. So my feeling is that we will probably see a difference. And in fact, in our pilot study that we did prior to the design of the study, we saw a significant difference in VO2 peak and quality of life measures in those patients who were part of the program. So we'll have to see if that pans out, right? Small studies are not as useful as full randomized control trials. So we'll see.
No, but that's great. And you've thought about a lot of the difficulties. So fantastic. And you mentioned another trial that you're doing. I wonder if you could explain that briefly.
Yeah, thank you, Dan. So the second study that we're doing, the title is STOPMEDCTRCD. So just like the word stop, and then med for medicine and CTRCD for cancer therapy or cardiac dysfunction. This again is driven by sort of patients. I just want to emphasize, in all of these study designs, we have 3 to 4 patient partners who work with us and help us prioritize what's important and the kind of research we should be doing. So this one study was driven by the fact that patients who have had cardiotoxicity and have completed their cancer therapy, they come to us a year or two later and said, look, I am 40 years of age. You have me taking a beta blocker and ACE inhibitor. My heart function was only 47%. You've told me that on every single ultrasound you have done in the past 6 months, my heart function is normal, my biomarkers are normal. I have fatigue with these medicines. I hate these medicines because it reminds me of the fact I had cancer. Can I get rid of it? And the answer usually is that I speak to my colleagues, and Dan, I think of you when I say I speak to my colleagues, and some of my colleagues will tell me, well, you've got cardiac injury, you should probably be on medications for the rest of your life. Others will say, no, I think you should consider stopping, so there's controversy in the field. So we started really by looking at retrospective data, and there were some patients who would ask us to stop in our clinical practice, and they really didn't want to take the meds, so we stopped them and we followed them. And when we did the small pilot study, at 2-year follow-up, we did not see a difference between the group in whom we stopped therapy versus not. And the patients we're talking about here are those who received anthracycline-based therapy, HER2-targeted therapy, or sequential therapy. So that pilot data was actually quite reassuring. The patient wanting to stop this is pretty loud. And then so we got a bunch of patients who are actually going through cardiotoxic therapy and had a forum with them to help understand if this was an important question. And they felt that they would want to see their response to a study that addresses this question. So we're fortunate enough to get, again, CIHR funding to do a 10-center randomized controlled trial. So we have 7 Canadian centers, 1 American, 1 center from the UK, and 1 from Australia. And what we're doing, we're looking at patients who have completed cancer therapy with anthracyclines or HER2-targeted therapy or sequential therapy. They must have completed their cancer therapy. We are only allowing moderate cardiotoxicity as per the ICOS statement. So it'll be essentially EF between 40 and 50%. The reason we chose that is because we know from the Spanish registry, if your EF falls below 40%, your prognosis is bad. We know that when your EF is about 50%, we're not even sure whether that should be treated or not. So we thought we'll focus on a place where there's potential controversy. So we focus on patients who have developed moderate cardiotoxicity as defined in the ICOS statement. And then now they have completed their cancer therapy, and on the most recent imaging, they have normal biomarkers. So NT-proBNP and BNP has to be normal. They have normal cardiac size and they have normal cardiac function. And there's no other indication for us to continue on with therapy, such as beta blockers for migraine or beta blockers for palpitations. There's no other indication. And we are randomizing these patients 2-to-1. So 2 patients will have their drugs withdrawn versus 1 patient who will continue on with it. Our measures of the outcome is we're using cardiac MRI at baseline to get a baseline assessment of their heart function, and we're bringing them back at 1 year for the outcome measure. But of course, when you stop medicine, you worry about safety. So each one of the patients gets a blood pressure machine given to them when they're randomized, so they take a machine home. We give them a very clear protocol to titrate off their drug. We call them 6 weeks later to check on their symptoms, so it's a virtual visit, and we ensure their blood pressure is good. We bring them back at 6 months for a safety echocardiogram to ensure there's no decompensation, and the 1 year mark is when we are looking at the primary outcome. It's a non-inferiority trial, and the primary outcome is defined as a binary cardiotoxicity. Essentially, you have to, again, drop your ejection fraction to less than 50% for that to be considered a significant event. So we started recruiting for our trial just about a month ago. We have had about 3 patients already recruited at our site, and we are just working on the Research Ethics Board approval at all the other sites to continue recruiting, and we are recruiting a total of 335 patients for this study.
Wow, that's a big number to fit that relatively narrow window. But yeah, that's really interesting that you basically took a in-person patient survey, and this was the type of question that they came back with. So that's really a great response to your patients. So congratulations there. And I guess how did you come up with, or how did you think you would come up with 335 patients that fit in this space?
Great question. Before I go there for a second, I really want to take this opportunity to thank ICOS, because we had submitted the grant to CIHR around before we got funded, and some of the feedback that we got is, how are you going to recruit patients? So who has these patients? How did you come up with the sample size and all of this? So Steve was gracious enough to help us send out a survey through ICOS, and this went out to, I guess, cardio-oncologists practicing across the world, and we had over about 140 responses. We had very specific questions. Is this an important question? what will you accept as a tolerance for reduction in left ventricular function, and we use the data really to essentially come up with our sample size. So it's based on estimate of what is acceptable to our cardio-oncology colleagues across the world, that we're able to come up with a sample size of 335. So I think this is a tremendous value that we had from the support of ICOS for us to be able to design this trial.
Wow, that's really neat. Fantastic. Yeah, and I think that depends on, I have done that or made that type of decision in the care of my patients, but it usually took them several visits for them to kind of beat me down on stopping their medicines, because, generally speaking, I don't really like heart failure, and if I give somebody some medication and it makes their heart failure situation better, I don't want to bail on that. So this is a very challenging question, but I also think that, a relatively young person who's on some sort of medicine now for the next 30 or 40 years, that's not a very enticing thought. And if you're physically doing well and active and all that, then I think it's totally valid to consider withdrawing the therapy. So
absolutely, I
think
think
this is really cool.
Yeah, depending also on the healthcare system, Dan, in Canada, if you are unfortunately in a stage where you're not being covered by your patient's insurance and you're not above the age of 65, you're paying out of pocket for your beta blockers and ACE inhibitors. And, it seems like a simple thing, but it's not. And many of the patients come back and tell me that they're fatigued with their beta blockers that I have them on, and then, of course, all the other side effects associated with it. So if I could potentially give them the opportunity to come off these drugs, I think it's worth trying. This doesn't mean we're going to succeed. There are going to be a subgroup of patients in whom there's going to be worsening LV function, but my hope is that if you put those patients back on the beta blocker or ACE inhibitor, that they will recover back again into the normal range. But my hope is that 95% of the patients, we can actually stop it. So I think it's still worth looking at, to try to answer.
Totally. That's a really great question, and wow, it's kind of impressive how you went about designing it. So thank you for doing it that way. That's really great. The one other thing I would just ask is if you have some sort of abstract or 1 or 2 page thing that we could put on the ICOS website to just let people know what you're up to, and for people to continue to be aware of what you're doing. So
yeah, no, absolutely. Thanks for asking, Dan. We'll be more than happy to do that.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.